Ladies and gentlemen, good evening and welcome to Brackley Town Football Club. This is the 14th of 15 planned meetings of the big health and care consultation, the Oxfordshire Transformation Programme. My name's Gavin Gray. I'm a freelance journalist, used to work in Oxfordshire for quite a few years, working for Central Television. I'm not part of the panel and I don't work for the NHS. I'm here to sort of try and get as many voices heard from you tonight, concerns, opinions, ideas, your thoughts on what you're about to hear and what's on the booklet and so forth. After some initial time that the panel will outline in a presentation about a very brief outline of what is in the consultation document, we'll then take questions and answers. So the vast majority of this will be given over to questions and answers. Just a few housekeeping points before we continue. No fire alarm is being planned, so if it does sound, the quickest one for you on this side is out of there. There's one at the back and there's an exit out there. And the assembly point is the car park. The toilets, there are some there, ladies and gentlemen, but probably the most convenient is at the back, and it'll disturb fewer people. Obviously, this is a no-smoking property today. If you've got a mobile phone, I'd really appreciate if you can either turn it to mute or turn it off altogether. There is an audio loop for those that require it, and it basically is the first 5-6 rows on this on the wooden floor. The dance floor, I think, is pretty much where the audio loop runs from. Just a quick word of advice as well. This is an open public meeting to which the media have been invited, so therefore I can't see the local journalists, but that doesn't mean they're not here. So therefore every word is a matter of record as such, and if photographs are taken, then you'll be in those. If you don't want to be in a photograph, then, and I see the photographer, we can let them know. If you let me know you don't want to be in a photograph, but we won't probably have that tonight by the look of it. So the schedule, as I said, will be a short presentation and then questions and answers. I am aware that quite a lot of people don't like, even in a smaller gathering like this, to have to stand up and ask a question. And that is why some of you have little postcard-sized bits of paper on the seat. We'll gladly take written questions as well. Because some people find that a bit easier. If you need a pen, just shout. We can sort you out with that. All right, now before the presentation, let's get the panel members to introduce themselves. If we start left to right as we're looking at it, ladies first, Diane Hedges.
Hello, thank you for coming this evening. My name is Diane Hedges. I'm the Chief Operating Officer in the Clinical Commissioning Group. I've worked in the NHS for some considerable time, having started in a practice and got the bug for working in the NHS. I lead the commissioning side in the CCG, which is working out how we use our resources, our money, to buy the range of services that we need to purchase to meet the needs of your healthcare.
Dr. Paul Park.
Hello, I'm Paul Park. I'm a GP in Banbury, where I've been for 8 years. I've worked for the NHS for 14 years. And I'm basically the GP who represents all my 100 or so colleagues in North Oxfordshire and 110,000 patients or so, including, obviously, a fairly large catchment of Horton, and represents them inside the Clinical Commission Group, the CCG.
Dr. Tony Berrand.
Good evening. My name is Tony Berrand. I'm the Medical Director at Oxford University Hospitals NHS Foundation Trust, where I'm the board lead for quality, among many other things. I trained in Oxford, qualified in 1983, and have been back living in Oxford since 1987, so 30 years here in Oxfordshire in the NHS.
And Andrew Stevens.
Good evening. I'm the Director of Strategy and Planning for the Oxford University Hospitals NHS Trust. I've worked in the NHS for around 34 years, and half of that time has been in my current post, where my key job is working with Tony, with our other clinicians, and with our other health and social care partners to develop our strategies and plans for our clinical services for the populations that we serve.
So that's your panel tonight, and you will note at the moment the lights aren't on them, and the reason for that is because if they're on there, you won't be able to see the presentation very well. But when the presentation's over, we'll put the lights up so that you can see the panel and so they can read what's on their notes and on the documentation as well. All right, if I could just ask then for the start of the presentation. It isn't very long. I know some of you might have heard it before, but I would urge you, please, just to listen to it, because there are some who haven't heard it before, and also you may want it on which to base the questions afterwards. Diane.
Okay. Thank you. So I just want to give you an outline of why we're here, what we're talking about, and I'll pass over to Paul Park, Dr. Paul Park, to take you through some of the individual cases. This is a 3-month consultation on a range of areas. We started in January, we conclude on the 9th of April, and I'll just run through the key areas we're talking about in this phase of consultation. Use of hospital beds. In this regard, it's a specific set of beds that are within the acute sites, so within Horton and within John Radcliffe, Churchill and the Nuffield area. Planned care, that's our jargon for when people go and see specialists, when they have outpatient appointments, when they have diagnostic tests. And we're very much keen that we see an awful lot more of that sort of work, the outpatients, the diagnostics, the support that we can give to diagnose and help you continue to manage your conditions and live your lives. We want to really see more and more of that at the Horton, and we'll talk more about that today. The acute stroke services, there is huge amounts of evidence now about the best way to manage stroke. As you know, it's a devastating event. If not managed well, then there are things we can do now to much improve the outcomes for people. So that's why we want to talk to you about that. Critical care provided in the Horton, really specialist area. You want the best expertise, the best intervention, the best equipment at the moment you need critical care. A reason why we want to talk to you about that. And maternity services, in particular obstetric, so where you need the specialist support of an obstetrician, where you're a mum likely to have a complex birth, complex baby, and therefore needing obstetric services. So there's a range of very specific areas that we want to talk to you about tonight, and they're described in more detail in the documentation that you've got. There are, we believe, a range of other areas that we need to talk to you about in the second phase of consultation, but today there's a discrete set, and I'll talk to you a bit more about the phases. Why do we need to change in the NHS? What is it that's driving the need to change? As we know, and it's great news, that people are living longer, the population is ageing, it's also growing. We are doing more and more phenomenal things in the NHS, things that we couldn't do even when I started my career, in terms of replacing knees, replacing shoulders, all of those things are routine now. There is much, much more we can do, and many more people we can do it for. The funding, we do get more funding. We don't get as much funding as we could ever use. So the ability for our funding to keep pace with all the things that we can do is one of our challenges. Preventing people becoming ill in the first place. There's so much more that we could do. Some of our money is not spent in the best way it could be. When we're spending money on beds, particularly when we're spending money on beds for people who don't need to or want to be in those beds, something we call delayed transfer, that is probably the worst use of our money, because it's not doing any good for the patients and it's not a good use of money. There's many more things we can do on the preventative side, working with general practice, strengthening the resources that we've got in general practice to help you live the healthiest lives. Inequalities exist across Oxfordshire. There is, between some of our wards, some quite distressing figures around the differences that there are in life expectancy and in terms of years of healthy life. Some of our buildings and equipment are not fit for what we need them to do for the future, and certainly in the Horton, some of the buildings actually constrain how much we can invest. And we don't have the right workforce to meet the demand, and we'll hear more about workforce, particularly in the maternity side of things. Why are we having to consult in two parts? Well, there's a huge amount that we want to talk to you about. In terms of when we move into the second phase, we want to talk about the whole range and opportunities around rehabilitation, around community beds and other areas. So at this point, what we're taking forward are those things that we really feel we've either had to make a temporary change, like, for example, the things we're doing with some of the beds at the moment, or where the necessity of the lack of workforce, or the lack of ability to have an obstetrician, drives us to need to make a change now, or the fact we know we could do better in stroke care, and the fact we know we could do better, we need to do it as quickly as possible. So that's why we want to do things in two parts. We want to get the things done that we need to. We also want to be able to talk to you about all the exciting things we can bring to the Horton, the more work we can bring up to the Horton. So I think just to clarify how we're going to manage some of those things that I talked about in the change, there is a lot more that we can do now where we can use diagnostics, we can use clinicians talking to clinicians assessing and supporting, and preventing people to have to go into hospital, either through diagnostics or through what we call the ambulatory pathway, where we're supporting people quickly to go back home. More and more use of technology, hugely important to us given the workforce challenges that we've got, and really important mantra about what we really want you to be is in your own bed, but supported by us with all of the other aspects. And some of these compelling things about if you are in a bed in a hospital and you don't need to be there, some of the effects that it can have on your well-being. I'm going to pass over to Dr. Paul Park to give you some more detail.
Thank you. Thank you, Diane. Can everyone hear me, by the way? Thank you very much. Okay. Before we go into the first of several videos, this part is about what we call using hospital beds differently. And what that really is about about what Diane mentioned earlier, which is delayed transfers of care. Patients who are in hospital but don't need to medically be in hospital, but they have anywhere they can go because they can't get the care that they would need at home or in another setting outside hospital. Certain members of the media call them bed blockers, which is rather unkind, but that is basically what we're talking about. It's probably not a very well-known fact because we haven't really publicised it or anything, but Oxfordshire, until last year more or less, and for 10, 20 years before that, had the worst delayed transfers of care figures in the country, which is awful. It's awful for a county with excellent healthcare, affluence, all that sort of thing. And the reasons for that were basically the same reasons you get everywhere, which is that basically you kind of imagine the whole thing as a sort of flow diagram. Your patient gets ill, they're admitted to hospital when they don't really need to be, when they could be managed outside hospital, but because there isn't a system for that, they go into hospital. They're going to hospital, and there's no real plan for discharging them while you sort of treat them, sort them out. Once they are treated, then there is nowhere for them to go because they can't go to home just by themselves. And either they could go to an intermediate care bed or to a supported bed in a care home or a supported bed at home, but there isn't the services for that because social care hasn't been mobilised. So the patients stay, and the longer they stay, the more likely it is that they'll get ill, and in fact, again, slip back into being medically required to be in hospital because they become more ill again. This is a terrible cycle and exactly the sort of thing you don't want to do with anyone. But therefore, for the last year and a half, we've really turned that around. We've been working really hard on making sure that basically when somebody's about to be admitted to hospital, but probably doesn't need to be, they or their GP can discuss it with a medical team who then can sort them out without admitting them. And then there's a process for managing them and planning for discharge when they're in hospital, and then making sure that there are beds outside the hospital, which isn't their own bed, there's support after that. But there's quite a lot of stuff there, and it's all good, but I'll just let the video speak to it.
Mum had a bit of a fall from her chair. She has dementia and she's disabled. I picked her up off the floor and it looked as though she'd had a stroke. I called the ambulance and they decided that she needed the hospital.
The Liaison Hub is a team of multi-professionals who are working together, based at the hospital, but the most of their work is actually carried out in the care home beds across the county.
Staying in hospital for the full extent of one's recovery is neither necessary nor desirable. Reducing exposure to other people who are unwell, reducing exposure to infections by moving into a hub facility increases the probability that someone's transition into wellness is going to continue without being broken up by the harms of being in a hospital environment. There's a huge psychological component to being cared for. Within 3 days, many particularly older or more vulnerable people will become incontinent, whereas previously they weren't, just by virtue of having the availability of someone to look after your most basic needs. So by expediting a transition from being in a cared-for hospital environment to a much more natural, homely environment, still within the support of a nursing home or care home, then we can make sure that we're avoiding that increased dependence which a lot of patients experience. We no longer see care as being a black or white division between pure hospital care until you're fully better and then discharged home. We don't like the idea of discharge.
Radcliffe told me we managed to find you a bed in the nursing home that your wife's in. And they said, we just thought it'd be good companionship for you, nice and be together. And I very much enjoyed it there, I really did.
I've seen really great results from people being enabled to get out of hospital, continue to have their rehabilitation and care, but in a setting that is much more homely. The liaison hub is a key component for ensuring that the whole system is using its capacity efficiently. I'm absolutely certain it's helping patients. The patients that I've worked with have really thrived.
The liaison hub made such a difference to us because actually it got Mum to the place that she really needs to be. I can't thank them enough. I'm really pleased with the way things went.
Okay, I hope that's... I think we could, for first point, we're going to take questions later. And secondly, there are indeed figures for how many people become incontinent as a point of remaining in hospital. I don't have them on me, and we'll talk about them later. But the point is that, let's talk about it later. But I would say, are we talking about people who have become incontinent because they're in hospital because they don't need to be, which is a significant figure, by the way? Are we talking about people who become incontinent because they're cared for at home? And where would you rather be if that is going to happen? That said, moving back to my flow, as it were, basically, the system has significantly improved in the last 2 years or so. When I've had three, as a GP, I've had 3 patients in the last week where I saw them. They were quite complex, quite frail, and they had multiple ongoing conditions, and I thought, I can't manage this. And 2 years ago, I'd have admitted them to hospital because there was nothing else I could do, and they would have been admitted, and they might have been fine, but that wouldn't actually been the best thing for them. But in each case, in the last week, I was able to pick up the phone, speak to the consultant in the emergency assessment unit at the Horton, and say, I've got this person. You probably know them. This is their situation. Do you think they? Could you see them? And do you think they need admitting? And they basically went, well, we'll see them and see how it goes. And in 2 out of 3 cases, they were not admitted. They were treated well, coming back to the emergency assessment units several times throughout the week. And that is much better for those patients. Equally, the patients who can move quickly through the hospital, there's something that's said about patients coming out of hospital but having to be cared in care homes and at home, which a lot of people say that surely that increases workload for you poor GPs who we all hear are overworked all the time. Well, that certainly can be the case, but actually in this particular case, with the way that the reconfiguration has happened, certainly in Banbury, that we were very worried about that, but actually it didn't happen. It happened more or less seamlessly. The care from Oxford University Hospital staff in care homes, in intermediate care, at home, was excellent, and it didn't really infringe on the source. I've barely got one call in a month about that sort of patient. And for that, I must say, I and other GPs in Oxfordshire, I'd have thought, were pretty grateful. Right, planned care. This is the really good news bit, as it were, and I think is a good news bit for Brackley as well. Basically, planned care is everything that isn't urgent care, which is a bit of a tautology, I guess. But the point is that there are a lot of things that are done at the John Radcliffe and the Oxford hospitals, such as outpatient clinics, scans, chemotherapy, day case surgery, all this kind of thing, that patients currently have to go down to those hospitals from Banbury, from Brackley, because that's where they're done, as it were. But the plan is to move, I believe it is 60,000 clinic appointments, 30,000 other things, scans, chemotherapy, day case surgery, etc., up to the Horton. So that basically that's 300 people a day. You know, a significant number of my patients will not have to go down to the Oxford hospitals anymore, and incidentally have a terrible time trying to park at the John Radcliffe. And at the Horton, yes, and of course parking still has to be approached, but that is huge, very good news as far as I'm concerned. And I'm sure we'll hear about what we think about the transport issues there, but I'll let the video speak to it.
Planned care is care that occurs outside of an emergency situation, and the three main components would be diagnostic tests, including imaging investigations such as CTs, X-rays and MRI tests, outpatient appointments and procedures that don't require to be performed as an emergency situation. Currently, a lot of patients have to travel to Oxford for various procedures and investigations, and if we could enhance the facilities within Banbury, then we could prevent those journeys from having to be made and try and deliver care to patients closer to their home. Looking at the catchment area of patients that travel to Oxford, it's projected that approximately 60,000 patients per year could be having their procedures and investigations in Banbury and not having to travel to Oxford for those investigations and procedures. To be able to deliver those services locally, we'd need to build a new state-of-the-art facility which would include diagnostics, outpatient facilities and improved access to certain day case surgery and routine outpatient procedures. We already perform some chemotherapy and renal dialysis treatments in Banbury, but the plan is to enhance those facilities and increase access to more patients to be treated locally. Patients often have to attend hospital for several different appointments to have their investigations and their outpatient appointments and get their results at the end. So what we plan to do with a one-stop shop is to try and reduce the number of attendances patients would have to make. So although we're trying to deliver care locally to Banbury, we also want to reduce the number of appointments patients have to make to achieve their diagnosis and treatment.
Okay, so that's hopefully fairly self-explanatory. This process, by the way, has already started. A new 64-slice CT scanner has been delivered and is working at the Horton right now. More CTs, therefore, will be done at the Horton as a result. And I'm looking into moving clinics, moving procedures, moving everything else. This is pretty much excellent news as far as I'm concerned, but we'll talk about that later. Stroke care. Okay, this is slightly complicated, and I shall try and explain it as well as I can. Basically, the way stroke care works in the north of the county, which is really where this change is talking about, is that if you have a stroke and the paramedic comes and the paramedic thinks that you are more than 4 hours after you've had your stroke, you're taken to the Horton. And if they think you're within 4 hours, they take you to the John Radcliffe. This is what they call the Manchester model, which is an older model of doing things. Unfortunately, looking at the figures over the last few years, it is clear that actually the stroke outcomes at the Horton are pretty terrible by national standards because the paramedic cannot actually reliably tell whether the patient is with under or over 4 hours of a stroke. This basically means that people go to the Horton where there isn't really the effective care for acute strokes in the way that they go to John Radcliffe. And more, the evidence is that everyone who's had a stroke, who has acutely had a stroke, should be taken to what they call a hyperacute stroke unit, or HASU, at the John Radcliffe. By the way, there are not many HASUs around the country. We're pretty lucky to have one at the John Radcliffe in Oxfordshire at all. And part of that is about the fact that the treatment of stroke has advanced hugely. Even since I was a junior doctor a mere 10 years ago, you can now mechanically retrieve clots, if that's what's causing a stroke, from inside someone's head, which would have been considered more or less fantasy when I was in medical school. And so ultimately, the change is about making sure that everyone in the north of the county who has a stroke gets taken to John Radcliffe, which I think will be much better for my patients.
At present, we have an access of all patients to the John Radcliffe for immediate assessment driven by 4 hours from onset. With the transformations that have been undertaken in stroke care in the last 18 months or so, where mechanical thrombectomy, where we use devices to pull out clots rather than just using drugs, we need to get patients to the John Radcliffe to enable equitable access from the whole county to this life-changing treatment. This is a very intensive, highly specialised intervention that very few centres in the whole of the UK can provide. And we're very fortunate that we have one of those centres here in Oxford. We also need to provide equitable access to the rehabilitation that enables the best recovery for patients. Through the early supported discharge service, which we hope to expand from the 6 postcodes it currently covers to the whole county, we hope that we will enable patients to have therapy in the comfort of their own home, enabling them to have therapy targeted and ensuring that they maximise their chances of returning to functional independence in the environment where they're going to spend the rest of their lives. And that's the whole purpose of the ESD being incorporated, early supported discharge, incorporated into this consultation. When it comes to immediate access to a hyperacute stroke unit, the major benefit to patients is the immediate assessment with specialist imaging and access to immediate specialist assessment by consultant staff, both physicians, such as myself and my radiology colleagues, where we can make the immediate decision whether mechanical thrombectomy is potentially helpful to patients. This is a decision where an immediate assessment and immediate decision really do enhance the chances of patients returning back to how they were prior to their stroke.
Yes, indeed. And the point I didn't cover in my preamble is that it's also about the best care of stroke is not only about whether you suck clots out of the heads as soon as possible. It's about all the multidisciplinary team stuff you put in afterwards, the rehabilitation, the speech and language therapy, and then the early supported discharge, which should be done as close to the homes as soon as possible. Critical care, another slightly complicated one, but again, I should attempt to explain it effectively. Critical care, or the critical care unit, is where the patients end up when they need the most intense care. And basically, there are several levels of critical care. The highest level, level 3, is basically the most high-risk patients, most difficult, most ill, who need intubation, tubes that are stuck down their throats to keep their airways open, ventilation with a machine that actually keeps them breathing, all that kind of thing. Currently, the critical care unit at the Horton is a level 3, or is capable of level 3 care. However, it doesn't see very many people with level 3 care. It sees about 40 people a year, slightly less, I think, now, actually. Less than 1 a week, which is obviously good in terms of people not being ill, but it is bad in terms of maintaining the training and experience for the staff who work there, because they don't see serious cases often enough. As a result, we said it was probably better for such patients to go to a level 3 unit at John Radcliffe and reduce the unit at the Horton to a level 2. It's worth pointing out that many people who go into a critical care unit don't do so from hospital having deteriorated. Many have to be taken in straight away. So it's a decision for the paramedic. Am I going to take them to the Horton where they have a level 2 unit, or the John Radcliffe have a level 3 unit? And it's better if they don't get taken directly to the Horton. But I'll let the video speak to it.
We have 3 adult critical care units at Oxford University Hospitals, 1 at the Horton, 1 at the Churchill Hospital, and 1 at the John Radcliffe Hospital. I suppose the levels of care reflect the complexity of care delivered to the patient and how sick they are. Level 3, which we sometimes call critical care, are for much, much sicker patients. These patients need advanced respiratory support, which is really the breathing machine, the ventilator. Critical care medicine is like everything else in life. The more you do, the more it becomes routine, and the surprises, the less they become unusual. If, as in the Horton, in the last year we had 40 level 3 patients, that means that's less than 1 patient each week, and in reality probably less than 1 patient a day. And that takes it into the numbers that makes managing them not routine, not normal business. Critical care facility at Oxford, there are about 1,900 patients there each year. So you can see immediately how the care of a critical care patient, which is never routine, but the general aspects of the care of a critical care patient becomes much, much more routine simply by having those numbers of patients.
Okay, so I think that's relatively clear. And yes, it's that would be, again, this is a decision based on safety and quality. And I think it's just worth summing up at this point. All four things you've seen so far are about safety and quality. We would have done them whether the money is, and whether we had loads of money or not. It's not about the money. The last one, maternity, is not about the money either. It's about the necessity. We didn't want to do it, but we had no choice but to do this. So in that sense, it is different from all the others. To cover maternity at Horton requires a certain amount of background, so I'll do that as quickly as I can. Basically, there was a obstetric-led, consultant-led unit at the Horton delivering babies until October last year. It was seeing about 1,500 babies a year, which is a small unit, sure. In 2012, however, the Royal College of Obstetrics and Gynecology, RCOG, who are the Royal College who oversees training for junior doctors for obstetrics, doctors who deliver babies, declared that they could not support training in a unit that saw fewer than 2,500 babies a year. And then the year after that, 2013, Health Education England, the national authority who definitely defines whether you can train people in certain places or not, said, focused on the Horton and said that the Horton could not have training doctors there in obstetrics. What that basically means is that you can't have junior doctors at Horton. It's for obstetrics, and that meant that after a certain amount of discussion, the Oxford University Hospitals and the Clinical Commission Group decided to put in a system which had non-training doctors, middle grades, to run a rota to cover the obstetric unit for the next few years. This is a very difficult thing to do and a very delicate thing, because you're basically taking non-training doctors in their last year before they become a consultant and ask them to work in this unit where they're not going to get any training experience or value. And we basically it couldn't have been done if Oxford wasn't such an academic centre, and you basically put academic doctors in that position. But it was very fragile, and it was very hard to recruit the doctors to the 8 or 9 that you need to have a full 24/7 rota. And basically, in June last year, Oxford University Hospitals were down to 4 doctors, and they couldn't get any more. And after careful discussion, but it had to happen quite quickly, the obstetric unit at Horton changed to a maternity-led unit, which is where midwife-led unit, do beg your pardon, a unit which has midwives and can only see the lowest risk births in October. And that has been the case since then. This is a cause of great concern and sadness in Banbury, I think it's fair to say, and certainly among my patients, but it was the only thing that could have been done. An obstetric unit without doctors is the least safe thing imaginable. And so, since then, of my patients who are giving birth, I think it's fair to say that some of them go to Warwick, some of them go to John Radcliffe, some of them have gone to midwife-led unit, and they've had an excellent experience there. It's been safe and good. But I shall let the video speak to it. Apparently.
We want to provide a high-quality, safe and sustainable maternity service. And although we provide a great service at the moment that I'm very proud to work for and work in, we can still do better. And if you look at women of today, we have sort of 2 groups of women. We've got a much fitter, healthy group of low-risk women, and we've got women who have more complex pregnancies. And actually, we want to design or update our service so that women can get the best outcomes for themselves and their babies and their families. So to do this, we need to look at the service that we provide and how we can make it better, make it more sustainable, and get the right women to go to the right teams.
The most important element of care for women in pregnancy and during labour is about making sure that they've got the right information to make the right decision about where they have their care and by whom. So that would be done in partnership with the woman and also her professional lead, which could be her midwife or her consultant obstetrician, depending on her pregnancy, and also her labour, her likely labour. So for women during the antenatal period, it's important that there's a risk assessment at the beginning of pregnancy to determine where they should have their care. So it would be about the right place with the right team. So if you've got a woman with a higher risk pregnancy, then there would be a requirement for them to have medical input as well as care from their midwife. But if they've got a low risk pregnancy, then for the majority of the women, they will have their care with their community midwife with some input from their general practitioner, which is also important.
The main challenge in maternity is recruiting obstetric doctors. So to recruit doctors, we need to make the jobs attractive, and we need to provide the doctors opportunities to train and to maintain their clinical skills. And currently, this is challenging, particularly in the smaller units. There's basically not enough clinical experience and clinical scenarios for the doctors to remain updated. Interestingly, there's a lot of information now and evidence that shows for these fit, healthy group of women, which most women are, they in fact do much better in low-risk midwife-led units. There's less clinical intervention and they get a much better experience and get home quicker with their babies to their families. However, for some other women, the pregnancies are more complex. And actually, as the health service developed, we've now found that these women, they do better if they're under the care of more specialist teams and have a different group or team of professionals looking after them.
Okay, and so there's still a fair bit of choice for women who give birth in Banbury and around. I mean, obviously, there's a midwife-led unit, which, to be honest, they didn't actually have before as a choice. They can go to Warwick, they can go to John Radcliffe, or indeed, if they are sufficiently safe, they can give birth at home. One thing to actually say at this point is to mention the split consultation, which has been controversial. Basically, this is the reason why the consultation was split. Back at the end of last year, the Health and Overview and Scrutiny Committee, or HOSC, which is basically the council committee that overviews health, every county has one, as it were, told Oxfordshire Clinical Commissioning Group that if we were going to keep the changes in the way we did beds, the first item, and the changes in maternity, the last item, then we had to consult on that as soon as possible. And we were planning to consult on the whole thing, as it were, the whole picture, sort of in the middle of the year. But since we had to consult on those two things very soon, we rolled this bit out with those two items, with reconfiguring beds and with maternity, and with a few other items that we thought was a good idea to cover at the same time. And that is basically why we have this phase 1 consultation now, and in phase 2 will be more or less everything else in the health system. All the documents, including this presentation, and by the way, it's a whopper, the videos are really high on size, are available at the Transformation website there. And basically, you can respond to the consultation by writing to us or completing the questionnaire on the website, or attending the public, and you can also attend the public meeting, which of course you're already doing. This is the penultimate meeting, so you've just got in there. I believe the last meeting is in Abingdon on Thursday. Is that right? Yeah. And those are they, in fact.
Okay. Dr. Park, thank you very much indeed. Right, sorry just to interrupt. Does anyone have a white Skoda? I'm afraid you blocked somebody in. Would you mind moving? Okay, we've just had somebody say, oh, there's a white Skoda block. Would you mind having a look, just to see? Okay. I'm sure your friends will fill you in with anything you missed there. All right. Great. Thank you very much indeed, Dr. Park. Did the panel want to just turn on the lights, or can we turn on the lights in the panel? Oh, they are on. They're on. Great. Okay. So it is slightly brighter than it was. All right. So into the question and answer session now. Just before the end, I'll ask the panel members to sum up, As I said to you, there are different ways of asking a question. Either you can put your hand up. Please, you don't need to hold them up for hours. I would try and note who wants to ask a question. A member of the team will bring along a microphone to you. And if you can just start by giving us your name and any particular connection you might have to the NHS, apart from being a patient like us all. But just repeat, if you would prefer not to stand up, but you really would like to ask a question, there are these postcards on which you can write a question and then get one of the team members again to hand that to me, or just bring it to myself, and I'll ask the question for you. Okay, so, yes, a gentleman here in a very smart blazer and a tie. Hang on there. There we are.
Sorry, thank you. My name is Blake Stimson. I, too, am a governor of the Oxford University Hospital Trust. But I'm concerned that nearly all this is referred to Oxfordshire, apart from once referring to Northamptonshire. And that's why we're all concerned, because Oxfordshire is a great place to live, wonderful, I live there, but Northamptonshire is where I live now.
Hold it in, sir. Hold the mic.
Marvellous, sorry, thank you. Now, my concern is mainly, funnily enough, maternity. Because I know I shouldn't, but I am. I'm a father. I had a daughter born in Oxfordshire who had to be rushed to the Churchill, and thankfully she survived. But it's not just a 5-minute journey from Banbury or Brackley to the hospitals in Oxford. It can take up to 4 hours. And I also happen to be, or was, one of the chairmen of the Oxfordshire Two Shires ambulance service, so I know a little bit about what I'm saying. Not a lot, but a bit. So I think that's something that needs to be looked at very carefully, how long it takes to get from Banbury to Oxford or from Brackley to get there. That's one thing. Okay. Now, sorry, I just want to continue about this business about maternity.
So keep the microphone at you, rather than you talking across it.
Even better. So I'm concerned on that side of it. I'm also concerned that all these...
Sorry, if you just turn it towards... That's it. Turn it towards me.
So I'm very shy, naturally, as the next headmaster. I'm bound to be. Sorry. But I think these are the concerns that occur in this, my town, Brackley. So if it really is the most important reason that we've got so many people here tonight. This is our home. This is where our children, well, not in my case, but many children were born, and they need that instant care. Our doctors are very good, and they're quite wonderful. I had a stroke 2 years ago, but I got over that quite well. I think so. Perhaps I'm suffering now. I don't know. But this is our town that needs looking at just as carefully as the Horton in Banbury.
So 2 questions, thank you. The first is, just if you hand that back to the lady there. So the first was about the maternity, a little bit in more detail. And the second one, and I think linked to that, was a little bit about that travel time. So, who wants to kick off with that? Dr. Tony Barrett.
So I'm happy to start by answering that. I mean, can I start by saying we've done many of these meetings now. I think I've done 3 meetings in Banbury itself. We've obviously been listening to a large number of members of the public, and I guess what's completely clear to me is the extent to which people want to feel they have the opportunity to give birth to their children where they live, and there's that sense of kind of born and bred in a particular part of the world. And I think the difficulty is, while I understand that desire alone cannot make that process a safe process in the modern age, where our expectations of success and of quality are very different, I think, to perhaps our grandparents' expectations of what born and bred might mean, which would also mean born and bred, but a certain number of children died. Or mothers died in childbirth, and things have changed dramatically, and we expect something really different. And we get something different, but part of getting something different is we have highly specialised services. We have subspecialties within obstetrics, where there are people who are specialists in particular kinds of abnormalities of the placenta, particular problems in the development of the baby in the womb. And people, I think, will be aware of these things from the television or other ways of understanding. So even obstetrics itself has become quite specialised. So the difficulty is that if we're to develop those skills and then have specialists who can maintain those skills, there is no substitute for experience. There is such a thing as critical mass. And it is not by accident that the Royal College of Obstetrics and Gynecologists have decided that if people are learning, then 2,500 births a year is a sensible minimum number for a learner to be in a unit. Obviously, the number of deliveries you'd need to do every year to maintain skills will probably not be at quite the same volume, but it will still be at a certain volume. So our difficulty, my difficulty as board lead for quality, as if you like the lead doctor for the hospital, is what do I do about a unit that is delivering 4 babies a day, not all of which need the services of an obstetrician, to maintain the skills of the obstetricians in that location? What do I say to you living in Brackley when you say to me, Dr. Barron, can you assure me that when my granddaughter goes to, or my daughter, whatever, goes to give birth in the Horton, they'll be seeing doctors who are completely up to date, absolutely skilled, able to do a caesarean section on their own in the middle of the night, or deliver the baby with forceps, or whatever. Can you promise me that that's all fine? And I think, as you heard Ms. Miller say in the video, and I think as we've already said, I can't say that. And I can't say that because we cannot recruit the doctors to provide that 24/7 cover. Just to be completely clear, to meet the recommendations of the Royal College around the amount of consultant obstetric presence that a delivery unit should have, an obstetric unit, we need 22 consultant obstetricians in post, working a rota continuously. That's because they work a night, they can't then work the next day, and so the mathematics of continuous cover means that that's the number that we require. And they don't do nothing but work on the delivery suite, of course. They do antenatal care, they do a range of other activities. So that's 22 for every obstetric unit that we're trying to staff and run fully. Now, we don't even have that number in Oxford, where we have thousands of deliveries a year, and we absolutely did not have that number in Banbury. So we are faced with a really difficult problem. We're faced with the problem of reconciling, if you like, the desires of people to be born and bred where they live, the desires of people to have excellent outcomes and absolutely safe services, and what we can provide in terms of the numbers of doctors available to staff a unit that gives you all those levels of intervention. So the alternative that we're suggesting is that we make permanent the arrangement whereby in Banbury there's a midwifery-led unit suitable for managing women who are pre-labour assessed as being low risk, with very clear protocols for how to escalate and transfer women whose labour is not progressing satisfactorily down to the main obstetric unit in Oxford. That is in keeping with the NICE guidance, it's in keeping with the best evidence, it's in keeping with what goes on all around the country, and it's in keeping with what happens in the rest of Oxfordshire. So, I know it's a long answer, but I think it is, while it's a very immediately emotional subject, it is actually quite complicated to work through why we can't offer people what we completely understand is what they want.
I do understand all you said, and I accept all you said. One of my concerns, as I pointed out, was that it's a hell of a job to get from the Horton.
That was what I was just coming on to, the travel time. Andrew, you were about to add something, I think, to Tony, and then I'll come to somebody maybe at the end about the travel time in a minute. Anyway.
I suppose just to respond to Blake's, I think, fair challenge, Blake, about the population served by the Horton, to reassure you, in terms of the planning work that we do, we absolutely take Brackley and Byfield, as well as elements of South Warwickshire, to be in the core catchment of the Horton. So when we are planning services at the Horton, we are planning it for that population, for the population of North Oxfordshire, the population of Brackley and Byfield, as well as elements of South Warwickshire. And I suppose a demonstration of that is the fact that a number of years ago, particularly in relation to maternity services, we negotiated with the services in Northampton that we would take over responsibility for community midwifery services for Brackley and Byfield, so that they are fully integrated into our service and are not a separate service. And that, that is a demonstration of the fact that we see those services as being part of very much the catchment. That 90,000 figure that we put up include residents of Brackley, Byfield, South Warwickshire, not just North Oxfordshire, because that is the population that, from a hospital point of view, we plan on.
Diane, did you want to add anything about how the consultation has been liaising with others across county borders or all?
Yes, travel times as well.
Yes, yep.
Yes, and I mean, in terms of it, clearly really important that when we're making assumptions about what services we can deliver at the Horton with the midwife-led service, that we need to be clear that other hospitals in Northamptonshire and Warwickshire can equally meet the needs of the patients if they would choose to go in those directions. So you would expect us to be liaising with the hospitals directly. So we've had hospital-to-hospital conversations, CCG to hospital, so commissioner to hospital conversations about what the plans might be. We've also got our ambulance trusts are liaising with each other. We heard more today. This morning we had quite a comprehensive presentation from our local ambulance trust about their plans and how they're responding at the moment. Obviously, we've got special arrangements at the moment with maternity services for an ambulance on site, but we need to understand what the future plans should be around that. So we do continue to liaise, whether it's the equivalent of myself, which is the people that are in planning and buying the services, or the hospitals themselves. So we directly have those conversations. You're absolutely right about the travel time. On paper, when we look at it, 45 minutes, something like that. But we do know that that's when it goes well. And we do need to recognise that for some people, the travel times will be an enormous anxiety, particularly when we've all had them, and I've had them as well, coming up and down to meetings. I have had the experience of motorways being shut and things like that. The key thing that our work will be doing is making sure that clinicians and mums and families are talking about being ready, and making early preparation. The thing that, again, we would want to reflect is our ambulance drivers, and that was what was said this morning again, what you're getting when you're getting ambulance support. You're getting really trained clinicians supporting you very quickly. So we've got a whole range of making sure in the risk assessment that mums are going through with, or potential mums are going through, that people know what the plans are and when are the right signs, what are the things to look for, when to move and allow that travel time. The travel times that we're talking about, whilst I'm sure I can imagine from your perspective that these feel long periods of time. These are not seen as exceptional travel times in relation to safety of care. So when Tony's talking about the board making decision about safety, that question of is it safer to try and go to somewhere where there may or may not be an obstetric doctor on hand, or is it safer to plan to have that travel time? It is much safer to make the travel time choice, as uncomfortable and difficult as that may be to hear. So we are looking at the various travel times. We're also mindful of the time it will take for an ambulance to come and get on site. But we were being reminded again this morning that our ambulance service is in the top of the country in terms of some of the response times. And equally, information was freely being shared about the volumes of episodes that are done really quickly, the ambulances that turn up really quickly, but also those occasions when they don't, when they take a while. And we as commissioners, we look into those incidents of when an ambulance has taken a long time. And if there was ever harm as a result of that, that also gets investigated. So I don't want to not acknowledge the significance of the travel times, but I would also say that does get taken into account when we're thinking about what is the choices and what is safe and what is not.
Okay, and a gentleman is that your question? Oh, okay. A gentleman in black there.
Thank you very much. My question is related to this. If we accept that we can't employ doctors, which we quite clearly can't for whatever reason, the reason seems to be, and I think we'll all agree, is because the accreditation for training was taken away. Is that the reason why? That's the main reason why we can't employ doctors. What efforts have been made to get that accreditation back? Because the videos mentioned that most people are low risk, or if we want to define people as low risk, surely the logical thing to do and the easiest solution to avoid all of this would be we have X amount of people giving birth in the catchment areas of the amount of hospitals. Why not divvy them up, or why not make the Horton more attractive? Why not try and encourage more people to go to the Horton and say, right, it can be a obstetric-led unit. but we need more people to give birth there, because there's, I'm sure, more than enough people in Oxford delivering to split between the two of us, so we can share the doctors and employ more doctors and make the post more attractive. That seems like the ultimate way of making it attractive.
All right, thank you very much. So who wants to start? So Jules' sort of question, but about the same thing. What efforts have been made to make it more attractive to hire people into the Horton?
What's and make more attractive for the mothers at the hospital? How do we get more?
Okay, and is it possible to split that more? Dr. Tony Barrett.
I mean, I can start. So I think the 1,450 figure that you had quoted to you was on the basis that already the highest risk pregnancies and expected deliveries were going to Oxford, because that's a kind of major specialist centre also for kind of difficult pregnancy. So there was already some filtering, if you like. I mean, I think your question is entirely reasonable. The question is whether the resolution, or to give you what you suggest, would be reasonable. It would essentially involve compelling at least 1,000, probably 1,500, maybe in the region of 2,000 women who currently live in the region of Oxford, Kidlington or whatever, to go to Banbury to have their babies. And I realise that some people would say, well, if I have to go to Oxford, why shouldn't someone else have to come to Banbury? So that is a counter-argument. But I guess at the moment we're not in a world where people are compelled to go to a particular place. They're given choices. Sometimes the choices are unattractive. So, you know, with the change that's happened, if you want an obstetric unit birth now and you live in Brackley, I completely understand. The choice currently is Northamptonshire or Warwickshire or Oxford, and I know that doesn't feel like a choice, but it's still, if you like, a choice. What we'd be saying is to people, you know, down in the south of the county, no, that you don't have a choice, we need you to go there, because I suspect that with the best will in the world, you will not persuade 1,500 women from south, to come up to Banbury. And I think that's all that we could do, because it is a numbers thing around the training recognition. So I think that, unfortunately, is where we are with that.
Andrew Steed.
Could I just build on that as well? And also, doing what you've just suggested wouldn't automatically solve the recruitment issue. Currently, across our patch, so the south of the country, 25% of posts, so a quarter of all training posts. So I'm not talking about the posts we had at the Horton. These are training posts at big units, including the John Radcliffe and some of the surrounding big units, such as Milton Keynes, and indeed John Radcliffe were probably better off than most. 25 of those posts, a quarter of all those posts are currently vacant because we can't recruit to them. So even overnight, that your solution wouldn't solve that recruitment problem, unfortunately.
Who could talk to... Sorry, Paul, did you want to...
Yeah. The thing I just want to add is that there is a significant problem with recruiting doctors in general in almost every specialty across the country. In the last 3 years of the junior doctor issues, shall we say, 15% of doctors in specialty training and 25% in GP training quit medicine entirely. They didn't switch specialties, didn't go to Australia, just quit. And that is a horrendous situation for recruitment.
And who can talk to what incentives have been offered to potential applicants to go to Banbury to work? Yes.
So we've enhanced the jobs in a number of ways. So listening to some of the comments that people made at the time that we were forced to make the emergency temporary decision, we'd already taken steps by increasing the salary. So we paid a premium over and above that available to other staff. We have offered to pay, because we are having to look right across the globe in terms of recruitment. So we pay the ability to get visas for the English language lessons that some of the doctors would require to get, because they have to get a special certificate. We've also looked at the way that the rotas are constructed to enable doctors to rotate to the John Radcliffe for some of their training, to try and, again, make that more attractive to them. And as I say, listening to some of the comments, people were saying, you're only offering these jobs for a year at a time. So we've extended the length of time that the jobs are available as well. So a number of things we've done to try and enhance the attractiveness of the jobs to potential candidates. But unfortunately, we are still struggling to recruit the 9 that we need to safely staff the rota.
All right. There was a lady with a sort of light brown jumper. Oh, your question's been answered. OK. I'm just going to ask this, because it came in, it's written, and it's about maternity. Why are women in labour being advised to come in when their contractions are only 3 minutes apart? that makes it virtually impossible to receive pain relief. Now, we do normally have on the panel somebody from who's a sort of expert, as it were, in midwife, but who could take that one on? I think it was very similar to a question asked in Banbury, actually.
I think the question was asked in Banbury. I'm not an obstetrician. My understanding is that's absolutely standard practice. I don't think that we're doing anything different there.
Yeah.
Okay. Right, and then there's a gentleman here. Is it maternity, your question, sir? Okay. Is your question at the back, the lady, is that a maternity question? Do you mind if we just stick to maternity at the start? So the lady at the back.
Hi, I'm Rosie Herring. I'm a local councillor and also mother of 3. And I just wanted to share, actually, with the audience some other information which hasn't been brought up yet. And that is, in the midwife-led unit, which is at the moment operating at the Horton, mothers in labour are not offered epidurals. They cannot be offered epidurals, so pain relief cannot be offered apart from gas and air to the mothers in labour, even if they start the labour and then decide that, you know, they actually do need it. And the other thing is that although the mothers have been screened to only have the low risk at the Horton give birth, a third of those mothers have had to be transferred either in labour or one thing that really worried me was that 4 had to be transferred after they'd given birth, but because the placenta hadn't been born. And having hemorrhaged myself with my second child, I was really worried about that because presumably they are at risk of hemorrhaging or of contracting an infection. And I'd like some advice on that. It doesn't seem like great care that we're giving to those mothers.
So the first bit was the epidural not being available, I think you suggested. And then the second one about the, as this lady had suffered, a blood loss there.
So shall I start?
Yes, Tony.
I think the important thing to understand here is we're not doing anything in the midwifery-led units that we run, and we're not withholding anything in the midwifery-led units that we run that is in any sense different from the national pattern of provision in midwifery-led units. So, and midwifery-led units, just to go back to that, have been very extensively studied and pronounced on by the National Institute of Health and Clinical Excellence as delivering equivalent outcomes for the baby and better outcomes for the mother for low-risk women than the same women delivering in an obstetric unit. That seems odd, and the reason for it is that when women go to an obstetric unit to have their babies, even if they're low risk, things end up happening to them because of the medicalization of the procedure that ultimately has an impact on the experience of those women. So, for example, they're offered epidurals for pain relief, great idea, but actually it's well known that what epidurals also do is increase the rate of requiring assistance in the delivery of the baby, what they call instrumentation. So forceps, suction, those devices and mechanisms to help get the baby out, because the woman doesn't push in the same way because she doesn't feel in the same way. I'm certainly not advocating that women need to be in lots of uncontrolled pain, but as we know, there are some women who very successfully, with a great midwife, will get through labour without requiring an epidural. So you're absolutely right, they're not offered an epidural. Women are not offered epidurals in midwifery-led units. And if their pain can't be managed through that whole gamut of other methods, you know, the bath and the balls and all the kind of modern ways of dealing with that, then those women do get transferred for pain relief. And that is absolutely standard. As far as the transfer issues go, we're absolutely tracking whether or not the Horton unit is performing in any sense differently to the ones we already run elsewhere in the county and to the national figures. And it is absolutely in the zone of what we would expect in terms of transfer rates. So as at the end of January, 61 women had given birth at the Horton. A further 12 of them had been transferred in the early stages of labour and then given birth at the John Radcliffe. and 4 women had been transferred having given birth at the Horton because there were problems with the delivery of the placenta. So you're right, that had happened. So that percentage rate for transfer during labour is absolutely standard. There had in addition been some postnatal mother and baby transfers for reasons to do either with how the baby was doing or with how the mother was doing. Again, the totality of transfers are absolutely within the expected rate for midwifery-led unit. Put another way, what midwifery-led units is offer low-risk women a 75% chance, roughly, of successfully delivering their baby in the MLU without any intervention, with about a 25% chance that they will end up being transferred to the obstetric unit, whether that's alongside or at a distance. And that is the national pattern, and that's the pattern that we're seeing played out at the moment with the Horton unit.
And Tony, just to be clear, when you say within the target figures, those are national target figures, not one that you...
Well, yeah, they're not really targets, because of course what we'd like is it doesn't have to happen, but it does happen precisely because of what people challenge us with in these meetings, which is you can't say there's no such thing as no risk. We agree. There is no such thing as no risk. There is low risk. And people challenge us and say, but risk changes. And we say, yes, that's correct. It does change. It changes in about 25% of people who need to move. But 75% of people are able to deliver successfully in the MLU.
All right. Thank you for clearing that up. There's a gentleman in a blue striped jumper. Was yours maternity? No. OK, right. So I think we, by the look of it, might go on to a different topic. So the gentleman with the T-shirt here with his brochure. Yes, please, sir.
First of all, I'm just a patient. Reading this book, and I spent 38 years in the civil servant writing this sort of thing, so I know how to read them and read inside them. Some of it, including the stroke, I must say, I agree with 100%. I think the stroke, having a central stroke unit, you can't argue with. I've had 2 relations with had strokes recently, not in this area. They went to a specialised unit in Bristol and both made fantastic recoveries. So that I would give 100% support to. But let's face it, the rest of this is done purely to try to save money. You're under a government remit, so is NICE, so is all the rest of the people you've said, their remit to save money. So let's go to page 18, where you're saying you're piloting systems for more care in the community. Great idea. Nobody's going to argue with you. But the funding for home care doesn't rest with the NHS, it rests with local councils. Yep. So where are you going to get the money for all of this extra home care? We've heard on the television umpteen times there just isn't the money available. Okay. You can't produce it, you don't fund it. You've got a marvellous thing here. You've had a recruitment drive was launched for care workers to support people in their own homes. Brilliant. How many have you recruited? That's the first. That's just on page 18. I'll go through a few more if you like.
Well, your argument's the money.
Those first.
Your argument's OK. So we did invite MPs, the local MPs and other MPs to each meeting. Well, my point is, obviously, the panel are not politicians, so they can't speak on behalf of Jeremy Hunt or the Ministry of Health, as it were. But Department of Health, I should say. But let me start off with Dr. Paul Park, a Banbury GP.
I of course, essentially agree with the thrust of what you're saying, in the sense that the health and social care system is financially under pressure as never before. Certainly, healthcare, it has been funded at roughly an increase of 1-2% a year against an increasing need of 4 to 5% a year, and that has been the case for the last 7 years, and that makes things very difficult. That said, as I said in the presentation, none of those things, none of the proposals we're making are down to money. We would do all of them whether we had all the money in the world. The reconfiguring beds is entirely about safety and quality and better care and preventing the delayed transfers of care for our patients. Stroke care, obviously, as you say, safety and quality. Critical care, safety and quality. Planned care, definitely safety and quality and better care and less travel for people. And maternity, we did it because we had to. fundamentally, while money is definitely an issue and definitely a thing we think about much of the time, it is not the driver behind any of the things that we are proposing. I'll let my colleagues from OUH talk about the rest.
Dr. Tony Barrett.
So I think the bit that I wanted to say was that it's really important to understand a few things that perhaps don't jump out of the presentation. When we talk about treating people closer to home, we are in this conversation, we're talking about people who were otherwise ready to leave hospital, who don't need the acute care that you get in hospital, who don't need to be around people in the neighbouring beds who are really unwell or confused or, requiring all kinds of things done to them in the middle of the night. We're talking about people who were on the way to being well and who were stuck for want of more rehabilitation and more support. And the innovation that was taken forward before Christmas 2015, so sort of just approaching 18 months ago now, was to release a substantial number of beds and divert the resource used to staff those beds into supporting patients going through what we called intermediate care beds. These were beds that were bought in the nursing home sector, but were being supported at a different level to what is standard for a nursing home. We're having visits from physiotherapists. We're having additional support from mobile nurses. We're having some additional medical supervision if necessary. So that shift in resource was done, and part of the reason that this bed closure programme is in the consultation is because, again, to come back to what Dr. Park told you earlier, what the HOSC said to us was, you can't just do that and do it permanently and not talk to the population about it. We accept that you've done it temporarily, and it seems to have made a real difference to those people who were trapped in the hospital, but you can't just do that forever and not talk about it. So we are talking about it, but it has been happening for 18 months. We have treated over 500 patients through that programme, and you've seen, you've heard one story through the video and heard another person being interviewed about his experience of going through it. We've had overwhelmingly good experience responses from the surveys we've done on patients who've been through that programme, and we have tracked things like their rates of readmission to hospital and how many of them died, because of course this is a group who are older and frail, and those have all been very encouraging outcomes in comparison with what we would previously have expected with people who remained stuck in hospital. So, if you like, if this was a new thing where we had no idea about the resource would come from, the money would come from, then I would entirely agree with you. But actually, we moved the resource, and it is happening already. What we're saying to you is we'd like to keep going. We'd like that to be permanent, rather than go backwards and have to dismantle the hub you heard all about and open up lots of beds to be staffed by, nurses we can find or agency or whatever, so we can once again keep people in hospital for months on end. We don't want that to happen. So that's where we're at with it.
And to be clear, the HOSC is the Health Overview
the Health
Scrutiny.
and Overview Scrutiny Committee. So it's just easier to say HOSC.
Indeed. No, it's all right. Just for those that might. The gentleman with the striped jumper here, I think, had a question. And then, Sir, yes, we'll come to you shortly. And don't forget, written questions I'll take in as well, of course. Yes, sir.
Thank you. My name's Alistair Nisbet. My question or points are about your proposal to move many services to the Horton. Now, I spent a lot of time in the autumn going up and down to the Churchill for treatment every day. Fortunately, I can drive. Had I not been able to drive, I did some timings from looking at bus timetables. I estimated that it would take me 3.5 hours each way to get to the Churchill from Brackley. That means going to Banbury by bus, get a bus to Oxford, and they don't just arrive and leave at the same time, and then finding a bus from the centre of Oxford up to the Churchill. Last bus back from Banbury is about 7:30. So unless I had an appointment well into the middle of the day, it would not be have been possible to do that each day by public transport. So I support the idea of moving as many services as possible to the Horton. I still have to have outpatient appointments from time to time. So can you give us any kind of timescale for when you expect all the new facilities, CT scanners, etc., to be available at the Horton?
All right, so thank you, sir. When will those services be ready? And also, I think Paul had mentioned, and just to clarify, 64 slice, perhaps somebody could explain a little bit more about that. Andrew Stevens.
So I suppose the first thing to say is this is a move that we have been dipping our toe in the water with already. So in recent years, we have opened up a renal dialysis unit. We've expanded at the Horton, we've expanded the chemotherapy unit, so patients with cancer who need regular chemotherapy appointments, where it is clinically appropriate, can have that at the Horton rather than having to travel to the Churchill. This month, we have opened up the new 64-slice CT scanner, so that can do more technically difficult scans. So those patients who previously had to go down to Oxford to have those scans can now have them at the Horton. So it's part of a theme that we've been trying to pursue over the years, but we now want to take a major step change. We will have to wait the outcome of the consultation, and on the back of that, we will take forward the planning that we've already begun. So we've already had initial conversations with the planners at Cherwell District Council around locations on the site, how high we can build buildings. But our first priority will be to build a diagnostic and outpatient centre. If I'm being honest, all that planning work is going to take a good couple of years at least, as well as the building. So what we're doing is also, alongside those longer-term plans, seeing what we can do in the short term. So one of the opportunities that's open to us is you'll be aware that on the site at the moment there is the Ramsey Treatment Centre. That has got spare capacity, both in terms of beds, in terms of theatres, in terms of outpatient facilities. That building comes back into the ownership of the Trust shortly. And so we are having discussions with Ramsey, with the Clinical Commissioning Group, around how, once we've got better access to that spare capacity, how can we start using that to start moving some of those 90,000 patients back early? So, as I say, it's part of a continuous plan that we've got, and we hope to be able to move quite quickly on some, although it'll take, it has to be honest, it'll take a number of years before we can do the full 90,000. But we are committed to doing that.
Dr. Tony Barrett.
And just to say, the other thing that you've half mentioned is, people will not have failed to do the maths and said, well, 300 extra visits, is that 300 extra cars to park, and what are you doing about that? So we are in conversation also with planners about parking arrangements and so on as part of it. So I think clearly to ramp up to full potential there will take time. I do think there's more we can do quite quickly. So there's a unit now that deals with day and ambulatory treatments, and that's been progressively month on month, seeing more patients in the last year. So we think there's a lot of scope in the short term, but the full thing, as Andrew says, will take longer.
Okay, and a gentleman here in a blue jumper. Yes, please, sir.
Can you tell me...
No, you're on. You are on.
Okay, can you tell me what it costs to keep somebody in a hospital bed compared with at home? The people, we hear a lot about bed blocking, and you've talked about that, but what are the relative costs? And so clearly it's more expensive in a hospital. Can you not transfer that cash?
We are, yeah.
Dr. Paul Park, so keen to jump in. He was there. No, go for it.
Sorry, yes, we have. That is what my colleague Dr. Tony was more or less saying. Was just saying a little while ago. And it's not just about freeing up the money, which is great, or indeed freeing up the space, which is less relevant. It's about freeing up the staff. Because the money freed up from having to take care of patients in hospital, they've been able to get hire 20 nurses, 8 nursing assistants, 3 regular consultants who all cover patients in nursing homes. I'll switch to Andrew in a moment to talk about what the actual costs are. But the fact is the money has been freed up and invested in that way.
So just to, in terms of the plans that are in front of you now, what we have done is all that money that we have saved has been reinvested into community services. This is where it gets slightly technical. We put up on the slide that the NHS is facing a huge challenge, which it is. The challenge isn't that it's getting its budget cut, because the budget will grow slightly each year. The problem is it will not grow enough to meet the demand. And so what we are trying to do is to get services that enable us to see more patients, and we can see more patients through having day treatments, for having day care, by supporting patients who are in private nursing homes, by having reablement teams out in the community. So it's not necessarily a question of actually saving money, it's about employing that money more efficiently so that we can see more patients within the resources that we've got.
But just yeah, no. So unfortunately, not. And it's partly because it's you know the ward spaces involved are embedded in buildings that exist anyway. You know, the staff are kind of embedded, so we can't give you an absolute cost. Our working assumptions are that it's pretty much equivalent. What we can tell you is that 4.8 million have moved from running those wards in the hospital to running the staffing that deals with the hub, the ambulatory units, and the other models of care that we've been describing to you.
All right. I noticed there's only been, I think, one lady's asked a question so far. So any ladies, please don't be shy. Right, lady in the yellow jumper, please.
Talking about all these extra appointments at the Horton, you've got a certain lot of specialists who are working, certainly at the Nuffield, who come to the Horton. So are you going to hope for a lot more specialists so that you can have all the appointments at the Horton running at the same time as all the appointments at the Nuffield as well? Or how's it going to work?
OK, thank you.
No, so obviously there is a growth in demand in services, and we will have to make sure that we are staffing accordingly to that. But in terms of that 90,000, so those are 90,000 outpatient appointments that are already taking place on the Oxford sites. And so they will transfer from the Oxford sites, together with the staff who support them, from the Oxford sites up to the Horton. So it's not a question of having to recruit more. It's about providing those services locally.
OK.
And the doctors do work for us, and we can ask them to move, and do.
OK, I'm not ignoring you, sir. It's just I'm going to try and find people who haven't asked a question first yet. There's a gentleman in a blue shirt and a blue jumper.
I'm a volunteer driver as well as being a patient at both the Horton and the Churchill. I have been a volunteer driver for almost 20 years, and one of the things I've noticed is the number of people which we take to the John Radcliffe for eye treatment or eye tests. Could not a lot of this be transferred to the Horton?
All right. First of all, thank you for your sterling service as a hospital driver. Dr. Tony Barrett.
So yes, it can. And we've had a lot of discussion with ophthalmology about moving more, for example, cataracts and other work here. I mean, obviously there's a certain amount of kit that they use, that some of which isn't portable, the most specialist stuff. But yeah, there's no question that more could be done rather than making people go to the eye hospital. And, you know, we have a great team of clinicians down there, but it is one of our highest volume, most pressured areas. And, you know, we absolutely are very keen to decompress that a bit. So I think there's a very strong push to get more eye services at the Horton.
OK. Any more questions from you? Yes, sir, with the beard, magnificent beard.
Yes, forgive me, I'm a bit lazy, I'll sit down. Where does the accident and emergency unit at the Horton fit into this scheme?
OK. Dr. Paul Park first, or...
OK.
Well, Diane. I think Diane perhaps does the... yes.
OK, thank you for that question. In terms of the phasing of the consultation, that's where I was saying there are some things that we're talking about now which are kind of urgent for resolution or making permanent. And those things do not include the A&E services at the moment. Phase 2, which we're talking about, is to look at our overall set of services that we're commissioning, which would include our accident and emergency services, both in the centre and in the north. We are increasingly getting guidance, and it's coming out virtually, weekly around how things should develop. And one of the things that we were hearing about in only the last week is about expectations around how we stream primary care support into the front of our A&Es. So I think the short answer to your question is there is nothing around what we're talking to today that affects the A&E, and we're being really clear in how we're doing this consultation, that we're making sure that anything that we do as part of this consultation should not have any knock-on effect or any interdependency to anything we look at next. But we will need to look at our whole range of services. And I guess picking up the comment a gentleman made a moment ago about, well, this is all about money. Actually, in terms of what we have to do as a commissioning organisation is decide, with the amount of resource that we have, whether it's workforce or whether it is money, is it delivering the best we can get out of it to get people to have the longest, healthiest opportunity of life. So we will be looking at the whole set of things, but what we're talking about today doesn't affect any of those other services.
And just, sorry to put you on the spot as well, is there a vague timetable now for Phase 2?
We would hope to be coming out on Phase 2 consultation in the autumn of this year.
This year, right, OK. And Dr. Paul Park, you wanted to add, I think.
Yes. Just to say that, yes, it's not in this consultation. But the A&E, and it depends, of course, what you mean by A&E or an emergency department. Yes, you already don't get heart attacks going to the A&E department, Horton. And we're planning not for strokes to go there, and major car accidents and so on. But that said, the A&E at Horton is extremely valued by patients and by the public and by GPs locally. It's pretty important for GP training in the area, and with the announced last week thing about a general practice component in A&E, and which kind of fits well with our plans for urgent care in the area. I mean, that's only going to strengthen the A&E at Horton rather than weaken it.
Sorry, when you mean GP component, you mean a GP being based at the A&E?
Yes, basically.
Basically, in the EC language.
They're asking for a bit more than that.
OK. I'm not ignoring... Well, I'm not semi-ignoring you. I just try to get other people. I'm ignoring. No, only for the minute. You've asked a question already, have you, sir? Oh, fine. Sorry. So the gentleman on the side there. Yes, please.
We've actually been told that there might be a medical centre up north of Brackley. I know this might not have nothing to do with it, but how will that affect all this system?
Sorry?
Right. So the gentleman's just said he believes there be a new medical centre is proposed north of Brackley. How would that, or how might that impact on this not on the consultation, on what you're proposing?
I'm not sure what you mean by a new medical centre north of Brackley. Do you mean the way the practices are merging and moving to a new unit? Because I don't know very much about that. Or do you mean about something else? If some clarification would be useful.
I'd just like clarification on it itself, actually. I know it's supposed to be amalgamating, but I say, will this have any effect on the Horton at all?
So I think the gentleman does mean the...
Yes, OK. As far as I know, it is at two practices in Brackley. Very good practices, I believe both, are merging and moving into a single building, which hasn't been built yet, but is being so, with the community hospital beds on a higher floor. Is that right? And that's all great, but I don't think that changes anything at the Horton, because it doesn't really change the situation of there being general practice and community hospital beds in Brackley, which is still be the case.
So should it go ahead or should it not go ahead? It won't impact on these by the look of it.
Yeah.
OK. Another. Oh, sorry. Thank you very much. Lady here and in a smart checked jacket.
Thank you.
Everyone's looking at your checked jacket now.
No.
Just bring the microphone up a little closer.
Yes. My name's Fiona Baker. I'm a local town and district councillor. I won't go to the maternity unit because I have a child with cerebral palsy, and all of those of you who know that's an accident at birth. Okay. I would never approve of anybody going to a midwife-led maternity unit. Okay. But moving on, what I'd like to know is what measures you're putting in place to improve the service that you offer at the JR, because I have been told by many of my people who contact me that people are waiting in corridors for long periods of time for beds. And this is not acceptable, really. So if you're going to be moving more and more people there, because you're removing all these facilities that we actually do want to keep in Banbury, we all want to keep the Horton with all the facilities we had before, But if you're going to move them to Oxford to go to these other hospitals, can you tell us what improvements you're making to make sure that people have a good experience when they're there?
All right, so you've got the right people to ask here about this one. Yes, Andrew.
So just to begin with, we have made a range of temporary adjustments to our capacity at the John Radcliffe to make sure that we can adequately cope. So that's meant increasing the number of delivery rooms, increasing the number of beds. We've also increased our theatre capacity as part of that. So we've increased our theatre capacity over and above the theatre capacity we used to have by putting a brand new state-of-the-art modular theatre at the John Radcliffe. So we have taken temporary measures to make sure that we have got more than enough capacity to cope with the additional patients coming to us, women coming to us. If there are examples, as you say, it is absolutely unacceptable if there are patients waiting in corridors. So we would absolutely wish to see those statements, and so that we can follow up and investigate them. As I say, we have taken a range of temporary measures to get us over the current transitional period. Were the consultation to lead to that change being permanent, then there are additional measures that we would take to increase the capacity still further to make sure that we have got more than adequate capacity for the number of women that would want to give birth at the John Radcliffe.
And can I just come in and add to that? So obviously Andrew's focused on the maternity issue. As far as the critical care issue goes, that's a direct Horton Hospital to critical care unit transfer. There is no people in corridors for that, and we're talking about 40 a year there. Similarly with the stroke unit, that's straight in to get to the stroke unit, and that's 100 a year. It is absolutely true that during the peak of the pressures that were nationally all over the media in January, then we also had some very difficult times. And it's true that from time to time still we're under a lot of pressure in the emergency department, but we do not have people in corridors, as you put it. So, you know, as Andrew has said, if there are instances of those, we would always want to be clear about what is being said and about whom and when, so we can look into it and reassure people as necessary.
Yes, as well. Yeah.
I just wanted to build on what Tony's saying. I think one of the things, and it kind of relates to the earlier question about A&E, it's quite clear if you go to the Horton A&E at a busy time, the layout is not sufficient for what we're expecting to be moving through there. So I think from a patient experience perspective, that may be where we get some of the feedback about how patients may feel that they would prefer more private settings. And I would agree with that, having seen it when it's very busy. What we need to use these processes of engaging with you. Phase 1 isn't about A&E. Phase 2 does need to be about A&E for the Horton, whether that is to say actually what we've got at the moment isn't fit in terms of the size of the number of people going through it to make sure we've got enough space to manage patients and support patients in maybe a more comfortable setting. So I hope that's not to contradict what Tony's saying, but I just think we should acknowledge that the Horton A&E at the moment is not optimum for the number of people going through it. And actually the setting we're asking people to be cared in isn't optimum for the clinicians to be working in. So that's why we need these sorts of discussions, these sorts of consultations are so important, because we need to understand the shape of services we need to put in place, and then we have to make sure that we do the development and building work and other things to make that happen and make it the right shape.
Yes, just hang on.
Does that mean... I've probably got a voice that'll carry anyway, but does that mean you'll be looking to improve the A&E in the future at Horton? Well, certainly from my perspective, I'd hope we could make sure that the building is fit for the number of people we're putting through it. Yeah. And at the moment, I think, you know, on days when it's busy, it's intense. It's a lot of people being managed very well, but in a very small setting.
Yeah. All right. Any more? Sorry, Tony.
No, and we do have similar pressures at times at the John Radcliffe, and we are developing business cases for significant expansion of that. It's complicated at the JR because it's quite constrained from a space point of view, but that's absolutely something that's part of our capital plan.
Okay, any more first time? Ah, great, yes, a couple here. So with the lady in the red and white coat, please.
In your projections, looking forward, have you taken account of all the building that's going on Because houses are popping up like mushrooms in Brackley and Banbury and Bicester.
All right, so a little bit about the population to look at. Start off with Andrew Stevens.
Yeah, I mean, just to say that the short answer is yes, we've been liaising with the county planners across the whole of the population, so that includes those in Northampton as well as Oxfordshire and Warwickshire, and have built those population increases into our plans. And I think we're going to need to make sure that we're doing proper scenario planning, because I think the potential of different projections will mean different impacts on our services. So I think we will have to make sure that as we develop our plans still further, we are flexible as those populations do come online. So we're very conscious of the huge growth that is going on, particularly in Brackley, but also in pockets of Oxfordshire as well.
Diane Hedges.
It was really just so if you take the example of the maternity, and that question obviously is a very live one. So we had, as Tony was quoting, something like 1,400 births. Our understanding through working with local authority colleagues is we can expect growth of 1% or so over the next few years. If we're going to get to a unit of the minimum size, that's 2,500. So it is, Andrew's absolutely right. We have been looking at the birth numbers. We've been looking at the growth, we've been looking at overall, but particularly on the children's side and with births, even with the numbers of houses we can all see growing up, there is no way that percentage growth would make a substantial change so that you could have that change in confidence around the volume of births and the level of training, expertise, etc. we'd be able to offer.
All right, thank you, Diane. And the gentleman right at the back here. Yes, sir.
What I want to know is about the increased flow that's going to the JR. How is that going to impact things like parking? I'm going there tomorrow, and I've got to allow at least an hour and 45 minutes. How your services are going to be stretched there as well. What's the future for it?
Okay, I guess an infrastructure type question. Yeah, Dr. Tony Berend.
So we have been very constrained in the amount of parking we've been allowed to have on our sites. We are in dialogue with the councils about that and seeking, in fact, to get agreement to build 5 multi-storey car parks across all of our different sites. It is a huge issue. We may not get agreement to have a vast number more parking spaces, but we think we can do a lot to improve the flow of traffic on those sites. And I just want to come back to the fact that we're talking about including the maternity and those small transfers, the critical care and the stroke. We're talking about 2 or 3 more patients a day going down to Oxford. We're talking about 200 to 300 a day coming up here. So we think the balance is very clearly, in favour, as it were, of doing this rather than against. But, I hope you'll have a good experience tomorrow, but I'm afraid you should allow that hour, and I'm really sorry that it is so difficult.
Obviously, there's 2,000 more homes coming to Brackley, and that is going to impact
All right.
going south.
Yes, with that, so the gentleman was just saying, sorry, because you didn't have the microphone, relating to this lady's point about the population. Yeah. All right, thank you very much. Right, I reckon we've got time for another sort of handful of questions, and I know the gentleman wants to ask one here, but I'm still after first-timers or anybody who wants to write one down. The gentleman sitting right at the back, please. Yes, you, sir. Right under the spotlight. Oh, you've come out of the spotlight now.
I'll sit in the spotlight if you want. A couple of observations. I was at Banbury the other day. There was a question asked by a consultant surgeon. He mentioned he'd done a lot of research into the maternity. He'd found 5 hospitals which were operating under similar figures to Banbury. Obviously, he was summarily dismissed from the stage. The gentleman in black who asked a question initially about reallocation of patients directing them towards Banbury, I believe Tony sort of dismissed that one as well by saying something, I don't think the ladies would like to do that. What effort has been done to actually request the ladies to do that? Because I'm sure, and having worked at the Horton and the John Radcliffe, so I'm quite familiar with both, I'm quite sure that with my experience there, everybody who worked at the Horton enjoyed it. So surely they would want
do you mean
that
the
to happen.
staff going? from Oxford up to Horton.
Yeah,
Staff.
yeah.
I thought you meant patients. Okay.
But I'd also like to ask a third question.
Right.
With a view to the Horton in general, and A&E's already been mentioned, if we lose the maternity, obviously the obstetric department has already gone, to operate a full trauma status hospital, don't you need people like obstetrics to man something like an A&E department? Does that not reduce the services? And obviously, ultimately, Banbury will become a day case unit and effectively a cottage hospital.
So three points, if my memory is just serving right. The first was about staff being encouraged to go up and work in Horton.
And patients as well, sorry.
Okay, well, now we're on to question 6.
As the gentleman in black originally requested.
And then there was the point as well that you mentioned about don't you need obstetrics if you've got emergency. And there was the first one that you mentioned about the... there was
a consultant surgeon who said he knew there was 5 other hospitals.
And we actually had that the other night, that there were 5 units. And Dr. Kieran Collison, whose sort of specialism this is, sadly is not here, but she actually had that pretty much that list and went through it and worked through it. But perhaps Dr. Paul
I don't
Parker
think she did. I think she said they'd looked at other hospitals. They didn't actually ask the consultant surgeon the hospitals he was referring to. Has that been addressed? Has that consultant
certainly all the questions are put on the website. So Dr. Paul Park.
Yes, the retired surgeon you speak of, we still don't have his list because he didn't appear to have sent it to anyone. However, I think we're still very happy to see the list whenever. A similar list was sent by Cheshire District Council in its response to consultation a little while back. And there are quite a few, agreed, there were quite a few hospitals on the list who had under 2,500 births, essentially. There only, I think, 3 of them had as few or fewer than the Horton. Some of them are in Scotland and Wales, where the system is fundamentally different royal colleges and things. But the majority, I mean, we have been going through and ringing up and contacting each of those hospitals. The majority have closed or merged or are under scrutiny themselves, under pressure to close or consulting to close. Basically, no one gets away with having a small unit and getting training. We'd still like to see that list from the retired surgeon. So if you know him, by all means, get him to send it to us. But at the moment, no one else seems to be, as it were, getting away with it.
You don't know the 5 yourself, sir?
So we have been looking. So just say we have been looking to check which services, as we had done all previously. So just to confirm which services, which units are smaller than the Horton. So the ones that we've come up with, and we'll need to check them against the retired surgeons list, are Dumfries and Aberystwyth, both of whom serve what are deemed to be remote populations. The Department of Health has a definition of what are remote populations, which is essentially how far you are away from the nearest A&E department or obstetric unit if that unit disappears. You may find this difficult, but under the Department of Health's analysis, there is no part of the population served by the Horton that is deemed to be remote. That under a blue light circumstances, all parts of that population can get to another A&E department, so by a blue light ambulance. That's not the case for the population served by Dumfries and Aberystwyth, because although they serve relatively small populations, they serve very large geographical areas because of the remoteness of the population. We believe one of the other hospitals is Barnstable, so we're in touch with Barnstable, but we know that there are discussions in Barnstable for the configuration of services, possibly not dissimilar from what is being proposed here. So we are looking at the challenge that was posed to us by the person at Banbury. Obviously, if he does send further information and evidence in, we will look at that. But we are looking to make sure there is no stone left unturned around possible ways of keeping the unit open at the Horton.
Can anyone answer the gentleman's point about the that don't you need an obstetrician if you've got an A&E? That was one of the gists, I think, of another point there.
I mean, no, you don't. So there are other examples of hospitals around the country that don't have that don't have obstetric units, but do have emergency departments.
Okay. Any other first-timers before I throw to the gentleman in the T-shirt, the former retired civil servant, whose name I've forgotten? No, right, sir.
Yes, thank you. I noticed that the question I actually asked first was about home care, and it got switched to the nursing home care. I understand the nursing home care. My elderly neighbour was put into it and told it was funded for 10 days, and they had to sort out how she could go home after that. So
Okay,
I fully understand how that works. But I did ask, 2015 this started, with a critical statement saying that you were going to... A recruitment drive was launched for care workers to support people in their own homes. How many have you found?
So when we first started this experiment, this pilot, we had a supported hospital discharge service. So that's a service that we as a trust provide that provides social care for patients coming out of our beds. We had 25 members of staff at that stage. In February and March 2016, we then took that figure up to 72. So we recruited an additional 47 social care staff, and we're going through and have been through additional recruitments since then. I think it's an absolutely great point to raise, sir. It is, I think, one of the biggest risks that health and social care face in this part of the world is around recruitment and retention. We are a very expensive place to live. Our housing costs are very high, and that impacts greatly on our recruitment. And I think it's something that we are going to need to keep on top of, because it is, as I say, our greatest risk. But to date, we have been successful in that recruitment.
Responsible for home care?
We are.
Yeah,
So within the terms of the proposals that you see before us, those patients that we're talking about are having their home care provided by us as a trust initially. So we are a registered social care provider. So although our core business has been providing acute medical care, because that the distinctions now are being blurred and you need to look at whole patient pathways, we got ourselves registered to provide home care as well, so home social care. So we run teams now that provide home social care.
Diane Hedges, did you want to add?
It was really just to add to what Andrew is saying about the reablement service, discharge and support and reablement service, which the Oxford University Hospital Trust is now responsible for. But in addition to that, we work with our social care colleagues about the pure home care budgets as well. And each year, in the last 2 years, we've brought another 10% increase in home care hours. Your question about how many more workers we're recruiting is a really good one. And actually, our biggest challenge is the number of home care workers we're retaining, because the turnover within home care services is very high. And that's something we need to work with. And obviously, with new retail centres opening in the Oxford City as well, there is a very clear issue for us around competing with retail and making sure that we retain the home care workers we have, and also recruit more on top. So they're the right questions. All I'd say is to really underline what Andrew's been saying, is that we are seeing more and more people doing work that's not linked to beds but linked to community support and outreach, and then buying more home care. But if social care colleagues were in the room, they'd be the first to admit that's our greatest challenge, is how we get sufficient home care staff.
Okay, I'm happy. Well, can I just ask you to be really brief, and then we'll see if there are any others.
How many times level 3 at the John Radcliffe has been full?
How many times level 3 has been full?
No, I mean, do you mean level 3 critical care?
You're talking about the number of level 3 beds that are at the Horton. You're doing away with them. You're going to send them to John Radcliffe. You've only seen the BBC television programmes where everything's held up. People are not doing operations.
All right, so at how many times is critical care full?
So I can't give you the figure off the top of my head. What I can tell you is that we are expanding our critical care units to take into account. So we are increasing the number of beds over and above those that are currently occupied at the Horton, to take into account both the 40 patients a year, the one a week that Tony mentioned, but also the other additional pressure on our critical care units. So we are expanding our critical care.
Sorry, to be clear, Andrew, to be clear, the number of beds you're adding is more than the
occupied beds and the number of patients that will transfer down from the Horton.
Right.
Yeah.
Okay. Any further questions? Okay, well, in that case, it's 10 to 8 anyway. So if I ask some members of the panel to sum up, and it looks like we're going to start with Diane Hedges, who's the Chief Operating Officer for Oxfordshire CCG.
Okay, thank you ever so much for your questions. And they really, I want to take the flavour of those to play them back to you to make sure we've really kind of been hearing the right messages. Without doubt, one of the key messages today is that travel times issue, the travel times on your own private transport, and then set alongside that travel time when you need to use public transport. And then particularly when you're John Radcliffe, but then hopefully in the new world when we've got lots more happening at the Horton, the issues of parking will equally be things for us to be very minded to. So travel times and parking. Getting doctors, how we get doctors, and actually the last conversation on how we get home care staff. So right across the board, how we get the skills and staffing that we need to support the services, which is in effect taking us back to our case for change. How do we deliver services to the range of needs? And challenges to us are, have we thought innovatively, creatively enough about how we bring doctors in, how we bring different staff in? A lot about maternity and the experience that mothers will have, any anxiety mothers will have, and importantly, the outcomes that mums need to get for themselves and their babies. I picked up that there is actually within the room a lot of understanding and hopefully resonance with our proposals around stroke services, the need to ensure that we get those outcomes right, but also the increasing local services for outpatients and diagnostics. Whilst there's some anxiety about parking and those sorts of elements, what I think we're playing to is people saying that that would make a difference. It would make a difference for your own lives in terms of local provision. So hopefully I've picked up the major themes, but if my colleagues on the panel, if you've anything I've missed.
Dr. Paul Pugh, did you want to sum up? Or
Dr.
No? Okay, Dr. Tony Berend?
I mean, I suppose for me, you know, as in some of the other meetings, what I pick up on is a huge amount of anxiety that's precipitated by the need to have these conversations. I think we've begun by talking about why we need to do that, which is about mismatch between the demands on services and the way that services are configured and what they're able to offer. I guess for me, the thing I'm still working out how we can best communicate and have a kind of conversation about is the need to change the idea of hospital and what a hospital is about. In a sense, in all of our minds. I think we've grown up thinking a hospital is a local place that does everything I need to keep me and my whole family safe, whatever's the matter with us. And I guess the truth is what we're asking you to accept is that if that idea of the hospital is what makes you feel safe, we're actually talking about something slightly different. We're talking about a different hospital to be the place to keep you safe if you have a heart attack and need clot-busting drugs and, you know, stents put into your coronary arteries to open them all up again. We're talking about a different place to go if you've got a high-risk pregnancy compared to a lower-risk pregnancy. And so the idea of kind of healthcare is getting more complicated, and it's not so tied to place. And I very clearly hear how difficult that is if you've been used to thinking about it as tied to place. I absolutely accept that. I do believe we have no choice with the way that what's available to us, but the cost in all senses of providing what's available to us, how we make that match what's needed. We can't have a major trauma centre in every town. We can't have a hyperacute stroke unit in every town. So, you know, I hope when you reflect on this, you will be able to see that these changes are still compatible with great healthcare and great outcomes, and in particular for those for whom it's a cherished thing, a really vibrant future for the Horton Hospital. But it will be a different hospital to what it was 10 years ago and 50 years ago and so on. It won't be the same.
Andrew, did you want to...
I think the only point I'd add to those of my colleagues, and it came up very strongly at the last meeting we had at Brackley, and for obvious reasons, it also came up, for example, when we were at Henley. What you share with Henley is that you are on administrative boundaries, and so if the population of Henley, a large proportion of those don't look to the John Radcliffe or the Oxford sites for their care, they look towards Reading. Likewise, you sit in it's almost the reverse situation where you don't sit in Oxfordshire, but you do look to Oxfordshire organisations to provide your care. We had the question about the Brackley development. I think we need to get much better as organisations working between ourselves, but also working with colleagues in Northamptonshire, with Northamptonshire GPs, so that when we come out and talk to populations, we can give you a full picture of what the healthcare means for you in its round, not just the bit that comes from Oxfordshire. We need to get much better at sitting down with colleagues from Northampton General, from the people who provide your local community care, the Northamptonshire Community Trust, so that we can provide a whole picture for you of what the future looks like, not just partial. So I think that's something that struck me very strongly, and that we need to get better, because as Tony says, I think what is being proposed is a really positive and vibrant future, but we need to make sure that you can see the whole jigsaw, not just certain elements of it.
All right, just to finish off by saying at the back of this pack are the different ways in which to get in touch with the CCG. It doesn't end here because the consultation remains open for another few days, and there is still time to either write in the nice old-fashioned way via Royal Mail, email, or other ways on the telephone as well with the CCG in Oxfordshire. Our next meeting is on Thursday in Abingdon, and it starts at 6:30. Thank you very much indeed. Thank you.
Can we just say thank you very much indeed to the panel for coming?